Welcome to the Teleflex Academy. Thank you for joining the Arterial Catheter Troubleshooting webinar. The learning objectives of this course include discussion of arterial catheter insertion techniques to aid in arterial catheter performance. We're going to describe the transducer setup and add-on devices that impact catheter performance once inserted, identify daily assessment criteria for indwelling arterial catheters, and discuss the importance of daily device calibration when utilizing arterial catheters. So first, we really want to do an arterial catheter overview. Arterial catheters have been used for many years in the critical care environment. We practice blood draws, continuous blood pressure monitoring, and serial blood sampling in a very critical element within the hospital. Arterial catheters dwell as long as clinically indicated or according to manufacturer's instructions for use. Arterial catheter dwell really depends on how you're using them and what you're monitoring and who is doing maintenance of these devices in your facility. Arterial catheters have associated risks and benefits and really should be removed when no longer functioning or no longer clinically indicated. The practice of having catheters idle for just-in-case procedures is no longer clinically warranted. A pressure transducer is a required element of an arterial catheter. The pressure transducer is required for blood pressure monitoring and requires its own independent maintenance, including leveling and zeroing, and ensuring that there's enough solution and pressure in the pressure transducer system for accurate blood pressure readings. Securement and flush solution is also a consideration when maintaining arterial catheters. Both function and well, and through this section we will review those both in depth. The pressure transducer setup. The pressure transducer is an essential component of the arterial catheter. Arterial catheters are the only catheter that require add-on devices for essential function. So when creating your pressure transducer setup, it's imperative that we use strict aseptic technique and we apply the pressure transducer distal connection of the tubing to the arterial catheter in a sterile fashion. Assembly and preparation is aseptic to reduce the risk of infection. This regulates the flush solution to keep the catheter patent. And what I mean by that is there's 2 cc's of flush administered through the tubing of the transducer through the arterial catheter each hour that the catheter is dwelling. This must continuously be pressurized at 300 millimeters of mercury to offset the patient's blood pressure and ensure that there's patency of the arterial catheter. Transducer setups are changed per hospital policy and recommended to be done on a 4-day interval. Please note that when you do your arterial catheter dressing change, you may be on a 7-day cycle. So we're going to discuss options on how to optimize the performance of doing a transducer change in between dressing changes. And also connecting to the monitor. If you use a pressure transducer and have an arterial catheter dwelling, it is required that you have that arterial catheter transduced to a monitor, as this is the threshold for alarms and allows us to monitor the patients who have catheters both in the groin, in the femoral region, but also in the radial region. So when you think about troubleshooting the transducer setup, there's several things that you really should be aware of. So we'll go through a few of them and talk through the solutions. So if your problem includes catheter occlusion, things that you really want to think of first is 1, start at the insertion site and work your way back through the tubing. Is your bag pressure maintained at 300 millimeters of mercury? And whose responsibility is it to maintain that pressure? Because if the pressure reduces over time and is stayed at a reduced millimeters of mercury, blood actually backs up in the catheter and can cause catheter occlusion. The other thing I want you to think about is if your catheters dwell for a long period of time, do you use saline in your pressure transducer or do you use heparinized saline? In pediatric practice, we continue to use heparinized saline to ensure catheter patency, but in the adult world, we have moved away from heparinized saline and really have moved to saline only. There are published studies that do show that heparin is an advantage when using a transducer on an arterial catheter for a long period of time. So if the problem is you have no waveform showing on your monitor, you really need to take from the arterial catheter back. 1, you're going to assess your patient, because if there's no waveform, do they have a blood pressure? Then you're going to look at the stopcocks to make sure they're all in the turned on position and they're not inadvertently turned off. Lastly, you're going to look to make sure that the pressure transducer wasn't inadvertently disconnected from the monitor. If it was disconnected from the monitor, you're going to reconnect, re-zero, and level your pressure transducer, and your waveform will return. If you do have a waveform present dictated on the monitor as a red line, upslope, downslope, but you don't actually have a pressure reading, this is the result of having the catheter and the transducer connected to the monitor via the cable, but we didn't actually level and zero the transducer once connected. If inadvertently disconnected and reconnected, a re-zeroing is always required. If you have an occurrence of catheter occlusion or repeat occurrence of catheter occlusion, you really need to consider the use of heparin within your catheter dwell policy, and also look at patients who have a hypercoagulability state and identify those that may benefit from the use of heparinized saline and the ones that we really want to just maintain with saline in the pressure transducer bag. If you have a dampened waveform, this is a result of several of the things I've talked about already, and one of them really is having not enough pressure in the pressure transducer tubing, maybe micro air bubbles in the pressure transducer tubing, meaning who flushed the line before you used it or hooked it up to your arterial catheter. And the other one really is a positional opportunity from a catheter malposition, and this results from the position of the actual catheter and or the tubing wrapped over the thumb, where the patient can actually move their wrist back and forth and cause flexion and distension of the arterial catheter. Then arterial catheter dislodgement, and this is really also a reflection of the tubing over the thumb. The more insecure or unsecure that the catheter body is, and the more ability for the catheter to piston, meaning move in and out of the insertion area, the more apt the catheter is to dislodge. And if you think about your critical care patient and the way that we secure our arterial catheters, and these patients are normally in the operating theater or operating room, and they come out to the intensive care unit post-extubation or getting ready to be extubated, and the first thing that they grab for is their ET tube. And when they do that, they flex and bend their wrist, and then potentially they kink their catheter. So dampened catheters really are a result of this. Also, catheter dislodgement is a direct result of this. And the last one of concern really is the blood in the pressure tubing. So if, for example, you draw blood out of your transducer tubing and you flush the tubing after you have aspirated your blood sample, and there's still blood that's remaining in the transducer setup, it could cause catheter dysfunction over time if that blood builds up. So it's really important to make sure that your pressure bag is inflated to 300, that you have enough saline solution or heparinized saline solution within the pressure transducer, and that you have no mechanical issues with your catheter indwell. So when you connect to the monitor, remember arterial catheters have to be connected to a transducer or else you'll have continuous arterial bleeding. These transducer setups then need to be connected to the monitor to transduce the actual invasive blood pressure from the catheter indwelling within the artery. So we must ensure that the pressure tubing is flushed and all air is removed out of the tubing, and that the pressure bag is inflated to 300 millimeters of mercury. We aseptically connect the tubing to the catheter, and you can do this either by a one-way stopcock and a 6-inch piece of high-pressure tubing that's dumped onto your sterile field, or you can do this by directly connecting your transducer onto your arterial catheter after insertion. We then level to the phlebostatic axis, or the level of the right atrium, and you can see that in the picture here that the patient's either flat or in no more than 35-degree angle ahead of bed. And this allows for each person within the hospital, one, to level to the exact same spot, but also to make sure that we are level to the right atrium regardless of the patient body habitus. We do have a couple options when we think about mounting the transducer. We can either mount it to the patient if it's a single transducer, so you put it on the arm, for example, or you can mount it to a pole, which is shown in the picture. If you mount it to a pole, the one thing that you have to remember is as the patient's position changes, you have to move the transducer up and down. If you mount it on the patient's arm, as the patient's position moves, the transducer moves with the patient. So let's just review some troubleshooting related to connecting to the monitor. As from an arterial catheter, the blood pressure is expected to use one blood pressure or another. And I'm going to give you an example. If you have a patient that's critically ill in the ICU and they have an arterial catheter indwelling in their radial artery and they have a good waveform with great blood return, you're going to use the arterial catheter that's indwelling for your blood pressure measurements. If you choose to use a cuff and a blood pressure, and the blood pressure directly correlated from the arterial catheter that's indwelling, you're doing a non-invasive versus an invasive measurement. So we really encourage you to pick one over the other. So when you think about your blood pressures not matching and not correlating, one, it will be very infrequent when they will correlate. The other one is when you look to see if you're doing a sample of an arm blood pressure non-invasively or an arterial catheter indwelling catheter blood pressure, and the numbers do not correlate together, you want to think of a couple different things. One, you want to check to see where the transducer is. Remember, it has to be level at the right atrium or the phlebostatic axis. And when you have that pressure transducer and it's below the actual phlebostatic axis, the actual blood pressure is displayed higher. And when you have your transducer and it's above the phlebostatic axis, then your blood pressure is actually demonstrated as lower. So the first thing you really want to do to make sure you have the truest blood pressure is, one, identify the best source, and two, make sure your pressure transducer is in the right location. If you have an issue with catheter occlusion and you're connecting to the monitor, you really need to make sure that your pressure bag is maintained at 300 millimeters of mercury. This is the one thing that's going to allow that 2 cc's of infusion to happen every hour to reduce mechanical occlusion. If you have a catheter occlusion on the monitor, you may display no wave at all, or you may display a very dampened wave. And I'm going to go through some dampened waves as we move through the presentation. You're also going to zero the transducer, and by doing this, you're going to zero the transducer, you're going to turn the stopcock in the up position, and zero to receive your waveform. And then the other opportunity would be if you have no waveform, if you're looking at your monitor, you're in the ICU and you're in your patient's room, and all of a sudden it's alarming and there's no waveform, you look up and maybe the cable became disconnected and you want to walk from the patient insertion area back to the monitor. So you're going to make sure everything is connected, and then you're going to level and zero. Remember, when you connect the monitor to the transducer that's connected to the patient arterial catheter, until the transducer is actually zeroed and the monitor accepts that zero, you will not have a waveform display, and nor you may not have a blood pressure display either. So if you do have a waveform without the pressure reading present, you want to consider releveling and zeroing your transducer. And if you have a dampened waveform, you want to consider heparin for your protocol for the flush solution, and also to make sure that there's no air present within the tubing, and to check the pressure bag. And I'll remind you, if you're inserting the catheter, who's monitoring and maintaining the catheter? And if you're monitoring and maintaining the catheter, who's actually inserting the catheter? Because each of these variables have high importance on the catheter dwell and the risk reduction strategies associated with them. So when you think about catheter dwell time, per the current guidelines, arterial catheters may dwell until no longer clinically indicated. And as a clinician, that means that you look at the site, there's no redness, no swelling, and no drainage, and that you actually still need to utilize the catheter for a therapeutic need. If you do not need the catheter, just know that the longer the catheter dwells, or if catheters remain idle, they have a higher risk of infection. Arterial catheters are not routinely changed per the current guidelines. We do not swap catheters out, and we do not routinely change catheters. If there is a suspect of infection, we would remove the catheter. And if there's a suspect of occlusion, you would never exchange over a wire the catheter, because you have to think of where that occlusion, that particulate that's on the end of the catheter, may go. And the last one is really catheter dwell. Catheter dwell is potentiated with use of heparin, so please consider what solutions you have within your hospital and your patient demographics to support catheters that need to dwell over a long period of time. So when you think about troubleshooting catheter dwell, there's a few things that really come to mind. So the first one's unable to draw blood. If you're called to the bedside because you're doing care and maintenance in an arterial catheter, or you're the primary nurse and you're trying to draw a blood sample for a routine lab, you really want to, one, assess the tubing, make sure the tubing and the stopcocks are open in the open position. You want to silence the alarm before you turn the stopcock to the off position to draw the blood, and you want to attempt to draw the blood. If for some reason you can't draw blood, you reassess, you relevel, you re-zero, and if the catheter is not functioning, you remove the catheter. In many times when you cannot draw blood from an arterial catheter, the catheter may have slipped outside the vessel and is sitting transient against the wall of the artery. So if you have a waveform without blood aspiration, you really need to consider, is that catheter tip still in the artery? Has it moved outside the artery and sitting within the space within the wrist? Can you take your ultrasound and scan over the distal end of the arterial catheter to see where that catheter tip is sitting? And if you remove the catheter after this episode of no blood return, you pull the catheter out and hold pressure like you normally would for a routine arterial catheter removal, you may not have any blood return. And that would be a very positive sign that the arterial catheter wasn't actually in the artery anymore, and it was just sitting against the pulsation of the artery. So for catheter occlusion, again, you're going to consider heparin. And then from an infection risk reduction strategy, you really want to reduce catheter movement. And it's no longer in our guideline to suture arterial catheters. So in your practice, think about how you secure your catheter. Do you use steri-strips? Do you use a sutureless securement device? Or do you use a dressing that has a reinforced securement option within the dressing itself? What your goal should be is to minimize the movement and the chevroning or the pistoning of the catheter back and forth under the skin. And you need to also consider removing the catheter if there is a suspect of infection, but also to institute the maintenance bundle to ensure the catheters are looked at every day and they're removed when no longer clinically indicated or they become a problem for the patient. During your daily maintenance, it is required that we do tests to make sure that the pressure transducer is accurate. And when I say test, I mean a square wave test. And on your transducer, you have a little blue, almost like a little pull tab. And what you do with the transducer for your square wave test is you're going to do this once a shift. And the square wave test is performed by flushing the arterial catheter and observing the waveform on the monitor. When you do this, you should have a nice box square wave that has a dynamic response in upstroke, over, and a downstroke. And it should be a perfect square with 1 to 2 auscultation. A square wave test checks the dynamic response of the entire catheter monitoring transducer system. So if you think about the entire pathway of fluid between the catheter and the transducer and the saline bag or the heparin bag, it's looking for any imperfections within the system. So you really need to check this every day. It's extremely important to obtain a high quality square wave in order to have extra confidence between what your arterial pressure tracing might be and to make sure it's reflecting an accurate reading. So when you optimally have a damp system, I'm going to review this a little bit because this is the normal wave. This is exactly what you should see in your patient in the intensive care that has an arterial catheter dwelling. You're going to fast flush the system with a quick release. You're going to pull on your little blue tab. You're going to quickly release it. It's going to give you a sharp upstroke that terminates to a flat line, followed by an immediate downstroke. This happens very quickly in a 0.12 second rapid return to baseline. That means it's going upstroke, across, and rapidly coming down and goes below the baseline. The waveform is clearly defined and has a dichrotic notch. That is very important when you're just differentiating between a central venous type of pressure line and an arterial waveform line. It's the dichrotic notch. When reviewing an over-damped wave, over-dampening occurs when activation of the fast flush generates a slurred upstroke. So you don't have that nice crisp upslope, unlike the prior slide, and a downstroke with no oscillations above or below baseline. This problem leads to both systolic and diastolic pressure readings that are underestimated of the patient's actual blood pressure. The dichrotic notch is not clear in the waveform. So the solution really is to check to make sure there's no air or blood in the transducer setup. Make sure it's flushed very well and that there's no visible air or blood that should be removed. Ensure that the catheter is not resting against the vessel wall. This might be from a positional insertion. You can actually manipulate the wrist slightly if it's in the radial region. You can use an arm board if required. Remember, an overdampened wave is also going to be caused by a kinked or malpositioned catheter. So if your arterial catheter is bent at the insertion area, you definitely want to apply an arm board to fix this problem. Change the tubing to a shorter, more rigid type tubing if the patient has returned from the operating theater with an extra amount of extension tubing placed in the arterial transducer. Let me give you an example. When I work in the operating theater and I have a patient that is on the opposite side of the room from my anesthesia machine, I'll add additional rigid arterial catheter tubing to my transducer so that I can reach my transducer and my patient without being in the way of the anesthesia machine. But when the patient returns to the ICU, it's important that we remove all of that tubing to make the waveform as crisp and clear as possible. So when you have an underdamped waveform, the underdamped wave occurs when activation of the fast flush generates a waveform that is characterized by numerous, more than 3 most likely, amplified oscillations above and below baseline. This is very interesting, and this occurs in the ICU. So let's walk through the problem first. This problem allows an overestimation of the systolic and underestimation of the diastolic pressure. This is what we sometimes call WIP. You see the catheter, you see the arterial waveform, and you see this peak that overshoots the systolic blood pressure. This generates a false high or low blood pressure reading. The solution to this problem really is to remove the excessive tubing, any multiple stopcocks from the system, and assess the patient. If the patient has the possible causes of tachycardia or high cardiac output, we have to treat the patient for these problems or symptoms, or just know that this is going to be their normal arterial waveform. Waveform accuracy. An arterial blood pressure reading relies on a crisp arterial waveform. Again, make sure your scale is appropriate to the patient. And if their blood pressure is 160/80, you really do not want their scale at 300/0. So optimize the scale first. The catheter whip, if you do identify catheter whip, is caused by vessel spasm and can result in a higher blood pressure, meaning systolic pressure is higher, and or underdamped wave, and we just reviewed that. So you can see that nice sharp upstroke, peaks out really high, and comes back to baseline. That is really caused from the inserter and or the patient condition. So the great things about reducing WIP would be to numb the patient prior to insertion, use ultrasound, and just assess the patient condition when you're trying to optimize waveformats. So catheter overdampening is caused by mechanical occlusion or underinflated pressure bags. I keep repeating the underinflated pressure bags because they have a very important part and very important role in arterial catheter performance. So make sure the tubing is flushed and make sure your pressure bag is always maintained at 300 millimeters of mercury. And on the bottom there, you'll be able to see a normal wave has a nice dichrotic notch. The overdampened wave just is a very sluggish arterial waveform that you can't really tell that's arterial because you can't see the dichrotic notch. And then the underdampened waveform that actually has the spike due to the vessel spasm. So when you're troubleshooting the waveform, some of this is a little bit of a repeat, but very, very important. If you have no waveform present, you want to make sure that the pressure transducer is in the on position and not inadvertently in the off position. Ensure that it wasn't inadvertently disconnected from the pressure transducer. And you also want to make sure that the pressure in the bag is at 300 millimeters of mercury. If you have a positional waveform, meaning that you're having to go in and reposition the patient's wrist to get an accurate blood pressure reading, you want to consider where the catheter is inserted. If it's inserted really close to the wrist, meaning just at the base of the thumb, every time the patient moves their wrist or every time their wrist flexes forward, you potentially can lose the catheter wave because the catheter will kink over time because the patient has their wrist in that position. As an inserter, we really want to move our insertion site away from the range of motion area down 2 to 3 centimeters proximal to the flexor crease on the wrist, or if you want to keep it simple, where the watch band would be if your patient was wearing a watch. If you have a poor square wave test, consider an arm board because remember, the poor square wave test is actually indicative of something in the circuit having mechanical failure. And that something in the circuit could very well be the insertion site when the patient's arm or wrist is bent forward. So please consider mechanical failure. So the importance of leveling and zeroing is probably one of the most important things that we do when we connect the arterial catheter and transducer to the monitor. The pressure transducer must be leveled to phlebostatic axis, as we've recovered this, but the position of the transducer is very important. So when determining phlebostatic axis, the patient's normally in a flat position. It's the level of the right atrium on the inserted side. And you can adjust the transducer as the patient adjusts in height or bed position. And as discussed, you can place the mount on the arm for the transducer and or you can put it on a pole. In hospitals today, it's still about 50-50 as to whether they pole mount it or they arm mount the pressure transducer. Please note that zeroing is required a couple times a shift, or at least once per shift, where leveling is only required when the patient's position changes. So leveling and zeroing. When you're troubleshooting leveling and zeroing, there's a few problems that may arise. So if you have a no waveform present and you have a pressure trace on the monitor, you must assume that the pressure transducer has been connected. It's connected to a cable, therefore reflecting a waveform, but because it hasn't been zeroed yet, there is no waveform showing or demonstrating on the monitor. If you have an invasive blood pressure, meaning you have a blood pressure in from a catheter that's transduced to the monitor, and you have a non-invasive blood pressure, which is from a cuff on the arm, on the thigh area, and they don't correlate, that's with reason. So let's walk through that a little bit. The first thing is, from an invasive blood pressure monitoring standpoint, you always take the invasive blood pressure monitoring first. It's the truest blood pressure in the patient in the region in where the catheter is dwelling. If you do non-invasive blood pressure monitoring, that's intermittent, it's external, and it can be changed or altered based on the size of the blood pressure cuff that we as a clinician decide to use. So going back to the transducer, it's very, very important that we have the transducer location appropriate and correct. So if the transducer is placed too high above the phlebostatic axis, then the blood pressure is reflected as being lower than the actual. If the transducer is too low below the phlebostatic axis, then the blood pressure is actually reflected as higher than the actual blood pressure. This is very important because we maintain such a very tight mean arterial pressure when titrating medications within the ICU units. The next one is really to consider the patient's circulation. If your patient arrives to the intensive care unit or is in your hospital and has septic shock as a diagnosis, think about the circulatory effect of septic shock. Is the extremity warm or cold? Do they have good capillary refill? Does the blood pressure reflect the therapeutic drugs that are being delivered to the patient? Remember, in septic shock, the body is very smart, and circulation is identified and targeted to the trunk for trunk perfusion. So the body is pretty smart to shunt blood from the peripheral circulation. So your arterial catheter that's in the radial in the wrist may not be as appropriate or correct as one that would be in the groin. So in septic shock patients who have peripheral circulation issues, are on high medications for vasoconstriction, may be fluid depleted, femoral should be considered for a site of insertion for accurate blood pressure reading. And the last one really is to remove that excessive tubing. Radial insertion considerations. So the radial artery is the most common insertion location for arterial catheter placement. And this is because it's easy to palpate, it's very superficial, and can easily use ultrasound for catheter insertion. Remember, using the radial artery also reduces the patient's range of motion and ability to do self-care. So those are some considerations we should think about when using the radial artery for arterial catheter insertion on the awake patient. The next one really is want to check capillary refill and extremity temperature. Anytime a catheter is indwelling in a vessel, it actually takes up an inner portion of the vessel and reduces circulation in that vessel. So, for example, in the wrist, if you have a radial artery, you want to assess the capillary refill of the hand and distal pulses up to the catheter to ensure that you have good circulation. If the catheter was placed in the groin, you would want to do femoral insertion site inspection, but also assess the pulses in the foot of that extremity and compare those pulses pulses, capillary refill, and extremity temperature to the opposite limb. And last, you do not loop pressure tubing over the thumb. During radial artery insertion, many clinicians will loop the pressure tubing over the thumb, and when we do that, we cut off circulation over the thumb, but also allow the patient to manipulate the catheter by moving their thumb back and forth. So, it is a best practice to loop the tubing towards the thumb, but not over the thumb. And I'll give you a simple explanation for this. When a patient goes to the operating theater for surgery, we remove their rings because we know there's going to be a volume shift in the patient during their OR visit. When the patient returns to the ICU and there's stasis in their bed and still have that volume shift opportunity, we don't want to add risk to pitting edema or function of the wrist by having the tubing looped over the thumb. And when your patient is awake, they can actually manipulate the catheter out of position just by simply moving their hand. So that should definitely be a consideration. So peripheral radial artery insertion. There's one picture here that has the red arrow for the insertion zone. So as I stated before, where the patient's watch would reside if they were wearing a watch is really the insertion zone for arterial catheter insertion in the radial zone. If you go above, more towards the base of the thumb, where normally you'd see arterial catheters inserted, the range of motion impacts the performance of the catheter. So in the opposite picture where you have the two wrists, you see the skin illustration says no range of motion, meaning if a catheter is inserted there, the patient will not be able to freely move their wrist, do any self-care, and will have to have an arm board in place. If you look at the other illustration, you can see exactly where the catheter should be outside of that range of motion area. So radial artery catheters, specifically for this site of insertion, because it is our primary site of insertion, there's a few things we should cover. So one is catheter dislodgement. The primary cause of catheter dislodgement is securement or poor securement of the exit site or management, but also the looping of the tubing over the thumb. So in your practice today, please consider not looping the tubing over the thumb, and what are you doing for catheter securement? Capillary refill also is a good indicator of circulation. So if you have poor capillary refill, which should be assessed every shift, you should consider the insertion location, move outside the range of motion area, and always compare one extremity to the opposite extremity. Remember, some of our patients have poor capillary refill normally. Now, from a cold and warm extremity, again, looking at circulation, is the extremity warm or cold, and is it warm or cold compared to an opposite extremity? If this is the case, where the extremity is cold, we have to consider circulation compromise and consider the risk and benefit of leaving the catheter in situ. Next is multiple insertion attempts. In practice today, we as clinicians have 2 insertion attempts to gain access. We should consider the use of ultrasound to increase our success rate and decrease risk to the patients receiving vascular access devices. Last is inappropriate circulation with the Allen's test. Prior to an arterial blood gas, which is just a simple needle stick into the artery to draw a blood gas sample, or placement of an arterial catheter within the radial area, an Allen's test must be performed to ensure collateral circulation from the ulnar artery. If you do not have collateral circulation verified by an Allen's test, you should not go above the intended insertion area. You should move to the opposite arm or consider a different area of insertion. Arm board use. An arm board is used to maintain dorsal flexion and reduce mechanical catheter issues. Now think about your ICU patients and how many of your patients use arm boards today. Arm boards restrict patients' normal wrist function, including normal daily activities. And arm boards are widely used in patients where their arterial catheter is placed at the base of the thumb where the thumb meets the wrist. Arm boards should be used when necessary and not routinely. Arm boards are placed on the back of the hand, keeping the wrist hyperextended. When performing daily maintenance and daily assessment, several considerations should be reviewed. A needs assessment should be completed each day to ensure the catheters are removed when no longer clinically indicated. In today's world of risk reduction and vascular access devices, catheters that remain idle that are not being utilized should be removed. Daily assessment should include several factors. 1. Site information. Is there redness, swelling, drainage? Is the dressing secure, and is securement in place? Circulation. Is the circulation of the extremity warm or cold? Is there good capillary refill present? And are there pulses distal to the insertion area? And remember, this should be done on both femoral line insertion and radial line insertion. The transducer assessment should include the location of the pressure bag and the transducer. Is the pressure bag inflated at 300 millimeters of mercury? How much fluid is actually remaining in the IV bag in the pressure transducer setup? And is there presence of blood in the tubing? Last, the arm board. If your facility utilizes an arm board to maintain catheter function, are they used appropriately? Is it restricting circulation, meaning is it loose enough so the patient can maintain flexion and distension? Is it clean and dry? And last, is it required? As clinicians, we should think about all of these things, but also we should be documenting every assessment point that we observe. So dressing considerations. When placing a dressing over an insertion area, it's important to understand that the entire insertion area must be covered with an occlusive type dressing. Today, we're able to use a sutureless securement device or suture in combination with the occlusive dressing for securement. It is recommended that we do not suture arterial catheters unless clinically indicated. Consider the use of an antiseptic dressing to reduce risk of catheter-related bloodstream infection. And when I say reduce the risk of catheter-related bloodstream infection, you should actually be monitoring arterial catheters for infection-related risk. So if you have a patient that is being cultured of all lines and tubes for suspected infection, arterial catheters should also be sent for culture during this examination. Dressing and securement. Catheter dislodgement is probably the primary dressing and securement problem. Secure at the insertion site and not looping over the thumb will increase the catheter insertion rate, but also the dwell of the catheter and the mechanical function of the catheter. Leaking at the insertion site, there's a couple different things we should be thinking about. If you're leaking at the insertion site because the connector between the tubing and the catheter is not secure, remove the dressing, secure the connection, and then reapply the dressing in a sterile manner. If the patient is bleeding from the exit site of the catheter, meaning around the catheter body, one, you want to check the patient's coagulation status and apply a pressure dressing where indicated. Hold pressure until stasis is achieved and reapply a sterile dressing. If the issue is catheter kinking, and this could be more common than you think. So the first thing that you should do when troubleshooting a catheter is go back to the last thing that we did with the catheter. So if we just performed a dressing change and all of a sudden we're having mechanical complications from our arterial catheter, whether it be the waveform or loss of the waveform, we should go back to the last thing that we did to the catheter. So when you think about catheter kinking, the insertion of the catheter should be proximal to the flexor crease of the wrist. And if it's not proximal, when you do a dressing change and you add add-on components, we may actually bend or kink the catheter. So very important to go back to the last thing that we did when considering troubleshooting, post-dressing, or securement change. I thank you very much for attending the webinar on arterial catheter troubleshooting, and I hope that you attend another webinar in the future. Thank you.